A very good day, my dear undergraduate and postgraduate students, and also the faculty members who have been a source of encouragement to me. The topic for the day is graft rejection, a seemingly short topic. That's why it's called SNIP, short notes in pathology. But it has got a plethora of terms to be defined. Look at this. Whenever we use a term, there will always be subheadings, and these we shall unravel as we proceed with the topic. On the other side, I am finding the number of organs that could be transplanted. There is a slight difference between them. Organs such as the kidney are thoroughly being studied, HLA type, before the graft is proceeded with. Whereas some organs such as the heart, they are an emergency mode of transplant, and hence such a thorough study will not be having time. Rejection is a major barrier to transplant because the recipient's immune system treats it as foreign and acts against it. Though there are many therapies nowadays to minimize and to prevent reactions, we should understand that there are immunological reactions and inflammations which act against the graft. Thanks to ResearchGate and this author for the pie chart that has been projected. These are the various organs and the percentage of which are being transplanted. The recognition and the rejection of the allografts. T lymphocytes and the antibodies against the graft react and destroy them. One word that we should be remembering will be the T lymphocytes. I have taken pain to put them in italics and underline them so that you people know down such terms. There is also a difference between the HLA alleles. That is why a fine HLA typing is mandatory, which differs in all except a monozygotic identical twins. The T cells recognize the donor antigens in the graft and they are called as allogenic or alloantigens. Anyway, rejection doesn't mean you are not good enough. It means the other person failed to notice what you have to offer. Nice. There are two pathways for the alloantigens. One is the direct and the other is indirect. Direct is the antigen is being presented to the T cells. Whereas in indirect, the host T cells pick them up and the graft antigens from the APC or the antigen presenting cells. So one is direct and the other is indirect through the antigen presenting cell. This is something like an opsonin. There can be the activation of the CD8 cytotoxic T cells. That is what I thought. But also the CD4 cells play a role in it, which we shall be seeing. In fact, the T cell recognition for the bacteria is much greater than the organ recognition. Hence, rejection is not as common as we think. There are different transplants such as the hematopoietic stem cells, solid organs such as the kidney, and the other solid organs. So the solid organ transplant I shall be taking in detail at a different class. See what is happening over here. Always the authors say that there are three things to be remembered. One is the epithelium, two is the endothelium, three is the interstitium. Along with it, there can be inflammation, thrombus formation, and necrosis. I hope the star makes you people identify thrombi that are getting formed and also a infiltrate. Usually it is appearing within the mesangium, but then it is going into the interstitium of the kidney. So there is a neutrophilic infiltration that is being mentioned here, particularly in a case of hyperacute rejection. And this is a very good reference for you people. Courtesy pathology outlines for this wonderful picture of a rejected kidney. Now, why do you have this precipitating factors or what precipitates the rejection? there are some preformed antibodies against the donor tissue. Why? Because earlier there would have been some antibody formed because of transfusion, or earlier transplant or attempted transplant of the same organ. 3. A HLA mismatch, and also strangely ABO blood group mismatch. And obviously you find that several of the patients would have already undergone some blood transfusion. Donor-associated endothelial antibodies and another procedures such as pregnancy, abortion, etc. also pave way. So this is a very important list that you people shall and will remember. And incidentally, look at the kidney over here. It is not the pale golden brown that you people usually see. I am finding extensive areas of hemorrhage and necrosis, which is again confirmed with this. This is the reference. UPMS, kindly find out what it is. In this one, I am finding a blood vessel that is having a thrombus. Probably there is some amount of recanalization also that is happening. Again, as in the previous picture, you find that there are the leukocytes which are infiltrating the interstitium surrounding. Also, there can be an inflammatory infiltrate of lymphocytes in the interstitium as well as an edema. These are certain things that you people will have to remember. I told you that there are 3 types. We shall see them. One is hyperacute, and the kidney has been taken as a prototype, though this fits for other organs as well. It is for specific antigens on the graft endothelial cells. And mainly it is mediated by means of this, or started by means of this IgM antibody. It is called hyperacute because it starts immediately or within hours. However, there can be some amount of delay also. So keep this in mind. There is an accelerated acute rejection, and there will be a raised creatinine in the case of the kidney. It looks cyanotic and mottled, what we had seen in the previous picture. The capsule is bulging, there is edema, there can even be rupture of the graft. And when it fails, the patient has to go back to dialysis. Now, what is there in this picture? So this is a blood vessel, and I hope you people are able to see the endothelium. We are able to see the endothelium over here. Now, what happens is there are the antigens and the antibodies over here. They come and get attached. It is unlike the R.A.T.S phenomenon, where there is a circulating immune complex which also gets deposited in the vessel wall and leads to similar changes. So once it is over here, again there is a cross-linking and there is the release of various mediators leading to some kind of chemotaxis, bringing in the neutrophils, and then a necrosis, a fibrinoid change, etc. Activation of the complement system is also present. Now, in the glomerular capillary, there can be thrombosis, there can be necrosis, there can be interstitial hemorrhage. And mainly what we are supposed to see is the endothelial cells with neutrophilic infiltrate. And there should be at least 5 neutrophils per glomerulus to call it a neutrophilic reaction. Hardly 1 or 2 is not adequate. And please be careful, diseases such as post-streptococcal glomerulonephritis also can be mimicking this. That is why there is a list of differential diagnoses that has been given, such as therapy or acute ischemia or hypertension with purpura, etc., DAC, etc. So this we shall be having in the corner of our mind. And immunofluorescence will be mandatory for always a confirmation. The light microscopy, we know it's not adequate in the renal biopsy. However, if there's going to be a circulating immune complex, you will be getting what is called as a lumpy bumpy deposit, which is subendothelial. This is classical of the post-streptococcal glomerulonephritis. However, in a case of rejection, there will be linear deposits because there are the antigens throughout and the antibodies formed are again getting deposited on it. A negative immunofluorescence, however, does not rule out because there can be a degeneration. Next comes the acute rejection. In acute rejection, you find that there is again the vessel wall over here, and then there is the antigen. But here what happens is there is the parenchymal cell, and then there is the antigen, antibody, etc. As a result of which you find that there is a damage to the parenchymal cell as well as the interstitium. Look at this monocytes, neutrophils, etc. coming into the scene, causing a break in the endothelium. And then there is a thrombus that is getting formed as well as the activation of the complement system. This is so far so good. And I told you a number of organs can be involved. This is one example that I picked up thanks to Moran eye care. There is a rejection of the eye transplant, corneal transplant, wherein there is a lot of congestion, edema of the eyelids can be very well appreciated. And an acute rejection, as I told you, it is mediated by the T cells and also by the alloantigens. It occurs days or weeks. Hyperacute is within hours. It can occur suddenly, months or even years later. After the tapering of the immunosuppression, again, a rejection can come into force. There are two types actually, and both are commonly present. One, as I told you, the CD8 T cells, or the CD4 cells, because they secrete the cytokines. These two things will be removed. So this is what the people are seeing. There can be a damage to the interstitium, there can be inflammation, endotheliitis. So I shall be coming back. Inflammation of the endothelials. And this is what I told you, the CD4 and the cytokines. This particular diagram, I would like you people to kindly memorize. So this is the antigen presenting cell. You find that it activates the T helper cell. There are a lot of these mediators which are being released. They can be actually chemotactic for the various cells. Tumor necrosis factor, series of interleukins, as well as the interferon, etc. As a result of which you find that all these cells come into action, because of which there can be inflammatory mediators. There can be the B cell becomes the plasma cell, leading to the production of the antibodies. Antibody-dependent cell-mediated cytotoxicity against the graft cells. Activation of the complement leading to lytic damage. You people must be remembering the C5b29, the membrane attack complex. And there is also the cell-mediated cytotoxicity. So all of these are there. Kindly do write this. So this one diagram, I think, will fetch you the marks. So same thing is there in the background. What happens is here is there is a tubulointerstitial inflammation. We call it tubulitis. Is it clear? Activation of CD4 and CD8 cells, we have already seen. And there can be the damage to the endothelial cells called as endotheliitis. Also, there can be necrosis of the intimal artery, which is called as R.A.T.S. So remember, tubulitis, endotheliitis, R.A.T.S. And the treatment will be immunosuppression. Chronic rejection. It is an indolent form of graft damage after several months or years. There is a loss of the graft function. A beautiful word. It is not totally that the graft is destroyed. There is a loss of the function. In fact, a graft rejection itself should be because there is a loss in the function, and a graft itself is made because the original organ has lost its function. The manifestation can be in the form of interstitial fibrosis, narrowing of the blood vessels, arteriolosclerosis, antigen antibody graft reaction, and the treatment more than 1 year, but progressive graft failure can occur. The T and the B cells are the culprit over here. B cells because they produce the antibodies. T cells, the T4 and the T8 cells I have already mentioned. There can be the production of these substances which lead to damage. Here, look at this one. There is a proliferation of the smooth muscle cells of the blood vessels. So there is a narrowing that is present. Chronic rejection. What is the pathogenesis? This is again the same thing. I would like you people to kindly go through. So there is an allograft. It is not direct, but then you find that there is something like an opsin and that gets attached to the antigen over here. And then there will be a series of reactions producing the interleukins, etc. So there can be the activation of the T helper cells or the cytotoxic T cells, the B cells and the plasma cells, as well as the production of the various NK cells and the macrophages of the monocytes, leading to the reaction such as antibody-mediated lysis, lytic enzymes, antibody-dependent cell-mediated cytotoxicity. So that is over here. I will not be repeating it. This is again a beautiful picture that has been taken from the net. Here what they say is it is a PAS stain that is over here. And there is a wonderful reference. I would like you people to go to it if time permits. There is a tram tracking of the membrane. The basement membrane is thickened around the glomerular capillaries, and also you find that there is a tram tracking because of the deposition of the antigen-antibody complexes. What are the complications of graft rejection in general? One, straight away it is a rejection. The graft is not going to function. Two, there can be a dysfunction, progressive dysfunction. Three, infection, very common because of graft. Vascular sclerosis, I have told you. Interstitial fibrosis. Damage to the adjacent host tissue. This we are not thinking of. There is only an inflammatory reaction and the various cytokines, etc., which are rejecting the graft. But at the same time, you find that the surrounding normal graft tissue, normal host tissue is also being damaged. Addition, this has been demonstrated in the bowel. There can be a small bowel rejection which can involve large segments, architectural distortion of the crypts, etc. And there can be perforation of the blood vessels. See what is happening over here. This is from a, thanks to this particular reference. So there is a loop of the intestine which has undergone and a blood vessel over here. There is an R.A.T.S that is there, and there is a necrosis. And when it comes to the loop of the intestine, there can be the addition of the loops as well as branching of the crypts. There can be perforation that is possible. This is a very, very, very important slide. Forget all the other things. Kindly memorize this. So, types of allograft rejection. So, it can be T cell mediated or it can be antibody mediated. It can be acute, it can be chronic. Again, antibody, it can be hyperacute, acute, or chronic. And what are all the various things? It occurs, the date of occurrence, whether the major histocompatibility complex is involved, what are the damage to the various structures of the glomeruli, interstitial blood vessels, etc. Chronic, it happens after repeated episodes. There can be sclerosis, fibrosis, etc. The entire thing is again given. It is more or less a summary of it. So there can be a previous dysfunction also, and all these happen. As a result of which you find there can be a basement membrane thickening. I told you about the tram track appearance, etc. So kindly by heart this particular one. It is worth its weight in gold. What is the prophylaxis and treatment? One is pre-sensitization. Two, drugs. Probably there are newer drugs and there is an entire list of them. Kindly go through. Cyclosporin, tacrolimus, plasmapheresis, PRA, panel reactive antibody test on the patient's serum. This is something that you can mention. And this is fine. So there is a patient in whom the graft has been successful, but then his body is rejecting the. Most fears of rejection rest on the desire for approval from other people. Don't base your self-esteem on others' opinion. I think it will fit a lot of people, including me. Thank you.